Welcome to the deep dive. Today, we're jumping straight into medical registries, specifically looking at vascular surgery.
That's right.
We've got some really good material, mostly from Rutherford's Vascular Surgery and Endovascular Therapy.
Yeah, it's a great source.
And our goal today is, to cut through some of the technical stuff and really understand how these registries impact patient care.
Exactly. When we think about medical progress, we often focus on the big clinical trials, the flashy breakthroughs.
Right.
But registries, they're kind of the unsung heroes working behind the scenes. So let's start with the basics. What is a medical registry?
Good question.
It's essentially a systematic collection of health data, demographic info too, for patients who share a specific condition or treatment. And it's all gathered for a predefined purpose.
A specific purpose, okay.
Yeah, that's key. It's sometimes called the inclusion principle. It dictates exactly what information gets collected and why. It's not just random data gathering.
So really focused, and I
Yeah.
saw mention of the MDR-OK model. Sounds a bit like jargon.
It does sound technical, but the idea behind MDR-OK is pretty straightforward and honestly quite powerful. It helps operationalize that definition.
How so?
Well, MDR-OK stands for Mergeable Data, Dataset Standardization, Rules for Data Collection, Observation over Time, and Knowledge of Outcomes. It forces us to think systematically.
Right.
It's about building data that we can actually use to improve things,
Yeah.
not just data that sits there.
Yeah.
Mergeable means we can link different pieces of information. Standardization, that's
Yeah.
making sure we're comparing like with like.
Apples to apples.
Exactly. Clear rules mean consistent data. Observation over time gives us the long view. And knowledge of outcomes, well, that tells us if what we're doing actually works.
Okay, that makes sense. So we know what they are, how they're structured ideally,
Yeah.
but why do we have them? What's the driving need?
Oh, several really important needs. The big one is just improving patient care. You can't improve what you don't measure, right? Registries give us that baseline picture of what's happening day to day in clinics and hospitals, the real world, basically, which can be quite different from a trial setting.
Okay, so improving care. What else?
Well, regulatory bodies like the FDA and payers, too, insurance companies, they use registries, especially for tracking new technologies, new devices after they hit the market. Think TAVR procedures.
Postmarket surveillance.
Precisely. And finally, registries help us overcome some of the limitations of randomized controlled trials, or RCTs.
Like what sort of limitations?
Well, for starters, it's not always ethical or even practical to randomly assign patients to different treatments.
Yeah, I can see that.
Plus, RCTs often have really strict inclusion and exclusion criteria. The patients in the trial might not look like the average patient you see in clinic, so the results might not generalize well.
Limited generalizability, okay.
And RCTs might not be big enough or long enough to pick up on rare side effects or safety signals. Registries, because they often include way more patients over longer periods in normal practice, are better at catching those low-frequency events.
And you mentioned benchmarking.
Yes, that's another big value. Hospitals and doctors can see how their patient outcomes stack up against similar centers. It provides context.
Got it. So they provide this real-world data, but you hinted that not all registries are equally valuable. What makes a good registry? It's not just size, is it?
Definitely not just size. The absolute core value comes down to data quality, and that really rests on two pillars: completeness and accuracy.
Okay, completeness first. That means getting data on everyone who should be included.
Exactly. If your registry is missing a big chunk of eligible patients, you have to question whether the findings truly represent the whole population. This affects what we call external validity.
Can you apply the findings broadly?
Right. This can sometimes be a bigger issue for registries focused just on a specific procedure, maybe compared to one tracking a whole disease. Or if participation is voluntary and expensive, some places might not join in.
Makes sense. And the second pillar was accuracy.
Accuracy. Does the data actually reflect reality? Is it correct?
Okay.
If the data's wrong, well, your conclusions are built on shaky ground. That impacts internal validity. Can you trust the findings themselves?
So how do registries ensure that?
Good ones have robust auditing strategies. They check both things. Are we capturing all the cases we should be? That's completeness. And is the information recorded for those cases correct? That's accuracy.
You also brought up an interesting point earlier, a potential tension between how complex a registry is and its validity. Can you elaborate on that?
Yeah, it's a balancing act. It's tempting to think, let's collect everything. More data must be better. Take, say, a joint replacement registry. You could collect just basic demographics, level I data, or you could go deep, level 4 fee, collecting super specific details about the surgical technique, the exact implant components, everything.
And more detail seems better.
Potentially, yes, for answering very specific questions. But making a registry incredibly complex has downsides. It takes more time, it's more expensive, and honestly, it increases the chance of errors creeping in during data entry.
Right.
And if it's too much of a burden, centers might participate less, or the data quality might suffer. So sometimes a simple registry that reliably collects accurate data to answer its main questions is actually more valuable than a super complex one that's struggling.
So fit for purpose is key.
Fit for purpose, exactly. Just complex enough to do its job well.
All right, so we have these registries collecting valuable real-world data. How does this evidence fit in with, say, the gold standard of RCTs? Where do they sit in the hierarchy?
That's a really important question. RCTs are generally considered the highest level of evidence, mainly because randomization is so powerful at minimizing bias.
Right, the gold standard.
But, like we said, RCTs have limitations that can't answer everything. Registry data, while may be considered a step below RCTs on the classic evidence pyramid, is crucial for filling those gaps. It provides complementary information.
And what kinds of studies typically use registry data?
There are three main types. You've got cohort studies, where you follow groups of patients over time to see who develops certain outcomes.
Okay.
Then case control studies, where you start with patients who have an outcome and compare them to similar patients who don't, looking back for differences in exposures or treatments.
Looking backwards.
Yep. And cross-sectional studies, which are basically a snapshot. They look at exposure and outcome at a single point in time.
Gotcha. And how do these registry studies differ from RCTs in sort of the practical details?
Several key ways. Enrollment criteria in RCTs are usually super strict. Registries tend to be much broader, reflecting who actually gets treated. More real-world patients.
Exactly. Treatment allocation in an RCT is random. In a registry, the doctor and patient decide, so it's non-randomized. Follow-up in trials is often very active and rigorous. In registries, it might be more passive, maybe relying on existing records.
And outcome assessment.
In RCTs, they often try to blind assessors to the treatment to avoid bias. That's often not possible or just not done in registry, so there's more potential for bias in observing outcomes.
Right. And you mentioned confounders earlier, these other factors that can muddy the waters. How do registry studies handle those, since there's no randomization?
Yeah, confounding is the big challenge with observational data, like from registries. Because patients weren't randomly assigned, there might be underlying differences between groups getting different treatments that affect the outcome.
So how do you adjust for that? Researchers use statistical methods, things like multivariable regression analysis, propensity score matching, or adjustment. These techniques try to mathematically account for the measurable differences between the groups to isolate the treatment effect. It's not perfect like randomization, but it helps level the playing field.
It tries to simulate randomization in a way.
Kind of, yeah. And actually, there's a really interesting development that tries to blend the two worlds. Randomized registry trials.
Ooh, randomized registry trials. Tell me more.
It's a clever hybrid. They leverage the existing infrastructure of a high-quality registry, the data collection systems, the participating sites, to run a randomized trial.
So you don't have to build a whole new study system.
Exactly. Saves a ton of time and money. You basically embed a randomization process right into the registry's workflow when a patient is enrolled.
Clever. Is there an example?
Yeah, the TASTE trial is a famous one. It used a big Swedish cardiac registry called Sweetheart. They randomized patients having a certain type of heart attack right within the registry to get either a clot removal procedure during their angioplasty or just standard angioplasty.
And the outcomes.
They tracked the main outcome mortality using the registry data itself. Super efficient, much cheaper than a traditional standalone RCT. It's a really promising approach.
Definitely sounds like it. Okay, let's shift gears a bit and talk about specific registries in vascular surgery. What are the big players, especially in the U.S.?
Right. In the U.S., the dominant one is the Vascular Quality Initiative, the VQI.
VQI.
Sponsored by the Society for Vascular Surgery, SVS. It's huge, over 850 hospitals and centers, thousands of providers participating. They track data on, hundreds of thousands of procedures across many different specific modules, like one for carotid procedures, one for aneurysm repair, peripheral intervention, and so on.
And its main goal?
Primarily, quality improvement. It collects detailed data on who the patients are, exactly what procedure was done, how it was done, and what the outcomes were, to help centers understand and improve their care.
I remember reading it operates as a PSO, a patient safety organization. What does that mean practically?
Being a PSO is important. It provides certain legal protections and confidentiality for the data shared for quality improvement purposes.
Ah, okay.
So participating hospitals can share protected health information within the VQI framework, generally without needing separate patient consent for that specific sharing, if it's used for improving safety and quality. The key is that the focus stays internal on learning and improving. Public reporting of identifiable hospital or surgeon results is typically prohibited under PSO rules.
That seems important for encouraging honest reporting. How do they ensure the data is actually reliable? Completeness and accuracy again.
Yep, they take it seriously. For completeness, they generally require centers to submit all eligible cases for the modules they participate in. And they have ways to check this, often comparing against billing data to catch missing cases.
And accuracy?
For accuracy, they use auditing. They do random audits of submitted charts and also targeted audits if data from a center looks unusual or outlier-ish.
That makes sense.
A really critical piece of VQI is the requirement for one-year follow-up on outcomes. Getting that longer-term data is vital for understanding the real benefit and durability of vascular treatments.
Absolutely. And they get feedback.
Oh yeah. Centers get regular benchmark reports comparing their risk-adjusted outcomes to the overall VQI collaborative. And interestingly, VQI recently merged its efforts with the American College of Cardiology's Vascular Registry, creating an even larger unified platform.
That sounds like a positive move. What other major U.S. registries should we know about?
Well, there's the American College of Surgeons National Surgical Quality Improvement Program, ACS, NSKP.
Yay. Heard of that one?
It actually grew out of the VA's program, VASQA. NSQIP is broader than just vascular, but it has options, including a targeted module for specific vascular procedures.
How does it differ from VQI?
A key difference is data collection. NSQIP uses specially trained surgical clinical reviewers to abstract the data from charts, which is seen as a strength for accuracy. However, the standard follow-up is typically limited to 30 days post-procedure.
Shorter follow-up.
Yeah. And like VQI, they provide semi-annual risk-adjusted outcome reports back to the participating hospitals. And then there's VASQIP itself, the National Veterans Administration Surgical Quality Improvement Program. That was the original model, really influential, but it's limited to VA hospitals.
Okay. What about internationally? Are there similar efforts elsewhere?
Definitely. VascuNet is probably the most prominent example in Europe.
Vascular.
Not a single registry, but more of a collaboration and umbrella group under the European Society for Vascular Surgery, bringing together national vascular registries or audits from over 20 countries.
Wow, that's broad.
It is, but it also means there's quite a bit of variation. Different countries track different procedures, collect slightly different data points, have different follow-up requirements.
I can imagine.
In some places, like the UK, reporting certain vascular procedures, AAA repair, carotid surgery, lower limb stuff, is actually mandatory, and the data is used for public reporting of outcomes.
Interesting contrast to the VQI PSO model.
Yeah. VascuNet has published some fascinating work highlighting these international variations in practice, patterns, and outcomes. But they also face big challenges in trying to harmonize the data, making it truly comparable across borders.
Harmonizing data across different countries, different healthcare systems, that sounds like a massive challenge.
It's a huge undertaking.
Yeah.
And that's really the motivation behind another group, the International Consortium of Vascular Registries, or ICVR.
ICVR.
It actually started as a collaboration between the US VQI and VascuNet, and now includes members from, I think, 14 countries. Their main mission is to share international experiences, best practices for quality improvement, and device evaluation globally.
So tackling that harmonization issue head-on.
Exactly. A lot of their work focuses on the nitty-gritty of agreeing on common data definitions for key conditions like peripheral artery disease, acute limb ischemia, complex aortic repairs. They often use formal methods like the Delphi process to reach consensus among experts.
Makes sense. You need a common language to compare notes. So we've got all this data being collected nationally, internationally. How does it actually circle back to make care better on the ground? You mentioned QI.
Right. The feedback loop is critical. It's not enough just to collect data. You have to use it. Most registries, like VQI and NSQIP, provide those benchmark reports we talked about.
Comparing centers.
Yep. VQI goes further, also providing de-identified data sets for research and letting centers query their own data in customized ways. But the real engine for improvement within VQI comes from specific QI programs driven by the data.
How does that work?
The physicians involved actually guide the analysis. They look for variations in care delivery, variations in outcomes, and try to pinpoint opportunities for improvement. This leads to things called COPI Report Center, opportunity profile for improvement.
COPI reports. Can you give us an example?
Sure, a classic one is the VQI COPI report on surgical site infections, SSIs, after lower extremity bypass surgery.
Okay.
They noticed pretty significant variation in SSI rates between different VQI centers, so they dug into the data.
What did they find?
They identified several risk factors for SSI. Some you can't change, like how bad the patient's artery disease is, but others were potentially modifiable.
Like what?
Things like the type of antiseptic skin prep used before surgery chlorhexidine seemed better. Also, longer operating times and needing blood transfusions were linked to higher infection risk.
Okay, modifiable factors. Then what?
Each center got a personalized COPI report. It showed their actual SSI rate compared to what would be expected given the risk profile of their specific patients. And crucially, it also showed them their own rates for using things like chlorhexidine prep, their average operating times, transfusion rates.
So they could see where they stood on those specific factors.
Exactly. It gave them concrete areas to focus on.
And did it work? Did infection rates go down?
Well, after that SSI COPI report went out, they definitely saw changes. There was a clear uptick in the use of chlorhexidine prep across VQI. Blood transfusion rates decreased, operating times trended down.
And the overall SSI rate?
The overall rate across all of VQI didn't show a dramatic drop initially, but importantly, those centers that did significantly increase their chlorhexidine use did see a statistically significant reduction in their SSIs.
So targeting the factor worked for those who changed.
Yes, and VQI has used similar COPI reports for other things, like reducing hospital length of stay after carotid surgery or EVR, and they saw drops there too. Even going back, the early days of VS-Cook in the VA showed big improvements in surgical quality just from providing feedback.
So feedback works.
It definitely can,
Mm-hmm.
although there's also a growing recognition now that just handing over the data might not be enough sometimes. You often need more structured quality improvement processes like PDSA cycles, Lean, Six Sigma to really drive change effectively.
Right. The data is the starting point, not the whole solution. What about clinical practice guidelines, CPGs? Do registries play a role there?
Absolutely. CPGs are meant to translate the best evidence into recommendations for routine care. The SVS, the Vascular Surgery Society, has actually worked with VQI to see how well surgeons are following their guidelines for treating abdominal aortic aneurysms AAAs.
And what did they find? Adherence good?
It was variable. They looked at 10 specific measurable recommendations from the AAA guidelines and found quite a bit of variation in compliance across VQI centers.
Interesting. Did it matter? Did following the guidelines correlate with better outcomes?
Yes, it did. They found that centers with higher adherence rates, especially to those guideline recommendations based on the strongest evidence, tended to have better patient outcomes.
That's powerful. Shows the guidelines work in the real world.
Exactly. And now VQI actually provides feedback to centers on their specific CPG compliance levels. So registries can, 1, show the impact of following guidelines, 2, help refine the guidelines themselves by seeing what matters most, and 3, monitor how well guidelines are actually being implemented.
Closing that loop again. Very useful. Now, you mentioned linking registry data with administrative data sets earlier, especially for devices. Can you expand on that? How does that work?
Yeah, this is a really powerful development for long-term follow-up. VQI has a specific partnership called VISION, the Vascular Implant Surveillance and Interventional Outcomes Network.
Vision.
They work with a group called MDR-OK, and what they do is link the rich clinical data from the VQI registry with long-term administrative data, specifically Medicare claims data.
So you get the detailed clinical picture from VQI and the long-term tracking from Medicare.
Precisely. This allows them to follow patients for many years, sometimes 10 years or more, after their initial procedure, much longer than typically feasible just through registry follow-up alone.
And what kind of outcomes can they track that way?
All sorts. Date of death, obviously, but also things like procedure-specific complications that might occur years later, the need for repeat surgeries or interventions, hospital readmissions, even subsequent imaging tests, and overall healthcare costs.
That long-term view must be incredibly valuable, especially for implanted devices.
Hugely valuable. For example, Vision VQI data has been used to look at things like whether reintervention rates after EVAR differ between patient groups over many years.
Yeah.
Well, one study showed higher long-term reintervention rates in Black patients compared to white patients after EVAR. Another looked at survival differences between men and women after different types of AAA repair over the long haul.
Insights you just wouldn't get from short-term data?
Exactly. These analyses would be incredibly difficult and expensive to do otherwise. Vision also generates specific reports for centers and allows for really robust analyses of how specific devices perform over time and what the real long-term outcomes look like for patients.
Okay, shifting to a potentially controversial topic, public reporting of registry data. You mentioned the UK does it, but the VQI doesn't. What are the arguments here?
It's definitely a topic with strong opinions on both sides. The main argument for public reporting is transparency and patient choice. The idea is that patients should have access to quality information to help them choose hospitals or surgeons.
Makes intuitive sense. What's the counter-argument?
The big concern is that it could have unintended negative consequences. One worry is that if outcomes are public, providers might become less willing to fully report complications or adverse events, which undermines the whole quality improvement goal.
Fear of looking bad.
Right. And then there's the issue of risk aversion. Surgeons might become hesitant to operate on sicker, higher-risk patients because those patients naturally have a higher chance of poor outcomes, which could make the surgeon's public report look worse, even if they're providing excellent care to challenging patients.
That's a serious concern. Have we seen these effects play out? You mentioned New York State's cardiac registries.
Yeah, the New York cardiac registries are a classic example. After they started public reporting, mortality rates for cardiac surgery did go down significantly, which proponents point to as a success. But there's always been debate about whether some of that improvement was due to surgeons becoming more selective, avoiding those high-risk cases, the risk aversion problem. It's hard to definitively prove either way.
And the UK's vascular reporting?
The UK's VSQIP mandates public reporting for certain vascular procedures, down to the hospital, and even individual surgeon level. This has raised similar concerns, especially about statistical reliability, when you have small numbers of cases for individual surgeons, and again, the potential for risk aversion.
Has anyone studied the risk aversion effect there?
Interestingly, one UK study looked at colorectal surgery outcomes after public reporting started there. They actually found no evidence that surgeons became more risk-averse, but they did see mortality rates decrease. So the picture is complex.
It really is. And some registries allow voluntary reporting.
Yes, some allow centers to opt into public reporting. But then you have to wonder if the centers choosing to report are representative of everyone, or if it's mainly the ones who already know they have good results.
A self-selection bias.
Potentially. And just to reiterate, the SVS VQI, because it's a PSO, specifically prohibits public release of identifiable hospital or surgeon outcomes. The philosophy there is that fostering an environment of trust and open reporting internally is paramount for driving actual quality improvement.
A different philosophy focused purely on the improvement cycle. Okay, looking forward then. What does the future hold for medical registries? Are they here to stay?
Oh, I think absolutely. They're here to stay. Especially in fields like vascular surgery, they provide unique, real-world insights that you just can't get any other way.
Yeah.
Particularly for tracking those less common but critical events or the long-term performance of interventions and devices.
What are the main challenges going forward?
Cost is always a big one. Maintaining high-quality registries, doing the audits, managing the data, it's resource-intensive.
Yeah, I bet.
But as regulators and payers increasingly see the value of registry data for surveillance and maybe even tying payments to quality, we might see more support, maybe subsidies or incentives for participation.
Makes sense. Any other big trends?
Yes. A really important one is the growing focus on patient-reported outcomes, PROs.
PROs, right. What the patient actually experiences.
Exactly. How is the treatment affecting their daily life, their symptoms, their quality of life from their perspective? Understanding that is becoming crucial for defining the true value of a procedure. So we're definitely seeing a trend towards incorporating more PRO measures into registries, maybe even having patients report data directly.
More patient involvement.
Yeah, making them more active partners in the data collection.
Well, this has been a fantastic deep dive. It's clear that medical registries are, well, fundamental tools for understanding and improving vascular care. From tracking everyday procedures to checking guideline adherence, monitoring devices long-term, it's a huge landscape.
It really is. And it's so important to remember that registry data isn't meant to replace RCT data. They're complementary. RCTs give us that rigorous evidence under ideal conditions. Registries tell us how things actually play out in the messy, complex, real world of clinical practice. Both are vital.
Absolutely. So as we wrap up, here's something for you, our listeners, to think about. As these registries get ever more sophisticated, collecting finer and finer details, where's the right balance? How do we weigh that desire for granular data against the absolute need for high quality and broad participation, which are the foundations of their value? And ultimately, how does this growing stream of real-world evidence influence the healthcare decisions that affect you or your loved ones?
A lot to consider there.
Definitely. Thanks for joining us on this deep dive.